All right, good morning, everyone. My name is Claire Rainey. I work at Type 1 Diabetes Exchange, and I've been working there for a few months now, so I'm relatively new, but I've had diabetes for about 5 years now. And today I'm going to talk about the emotional impact of clinical encounters among people living with Type 1 diabetes. Before I dive in, I want to take a moment to acknowledge my audience. I know I'm speaking to clinicians who go above and beyond when it comes to empathy and connection. You all are a part of T1DX. You are at this conference right now, which is amazing. So my goal today is not to criticize, but to bring awareness to some of the negative experiences people with Type 1 face, and then build on the great work that you're already doing and think together about how we can make positive, supportive experiences the norm for everyone living with Type 1. Okay, so some background to start off with. So we all know that Type 1 misconceptions contribute to judgment and stigma that can affect people with Type 1 diabetes across many aspects of their life. And these misconceptions are often seen in the media or among friends and family, but they also occur in clinical settings as well. So the aim of this study is to explore how communication in the clinical setting can influence people with Type 1's behavior and the quality and frequency of the care that they receive. So this study explores the impact of judgmental or dismissive clinical interactions on their behavior and attitude regarding their care, how negative experiences can shape trust or mistrust in providers and future engagement with care, and the importance of clear, respectful, bidirectional communication in fostering person-centered care. The study employed a qualitative approach. We asked people from the T1D community, including people responding to the question of the day from the T1D exchange, and we also asked T1DX staff members living with Type 1 to share personal narratives and insights based on lived experience. So we gave them the following prompt. We're exploring how trust is built or broken between clinical staff and people with Type 1, especially through communication. Often, trust erodes when staff speak or act from a place of judgment or assumption. We're gathering real experiences to better understand this dynamic. So we asked them kind of three primary questions. Have you experienced judgment or assumptions from clinical staff? How did you respond? And how did it affect your ability to stay open or engaged with them or that clinic? And I wanted to note that the clinical staff includes non-diabetes specialist care, endocrine care, primary care, frontline staff, check-in staff, staff who answer the phone, basically anyone who plays a role in your clinical experience from start to end. Okay, so 6 themes were identified across the stories shared, and we used inductive coding to analyze the stories. So these are the 6 themes we identified. The first is moral judgment and negative framing. The second is dismissal of lived experience, misinformed care, unprofessional interactions, emotional guarding, which refers to withholding and withdrawal, maybe some disengagement and loss of openness and trust between a patient and provider. And then inadequate support, meaning the patient is not receiving all of their needs met. They have unmet needs. Patients are left feeling isolated or unseen rather than empowered and understood. Okay, so I wanted to highlight a few of the stories that were shared. So I'm going to read them out loud just because we have time. But this is the first one. This person has been living with Type 1 for 5 years. I had just made the switch from a pediatric endocrinologist to an adult endocrinologist, and it was my first appointment at the new clinic. I didn't know where I was supposed to go for the appointment, so I asked the front desk security person. I asked him where I needed to go for my appointment, for my diabetes appointment, and he said, "Diabetes? You have diabetes? You don't have diabetes. You don't eat a lot of junk." I was baffled by his response to my simple request of asking him for directions. I felt the need to tell him that type 1 is not caused by eating too much junk food. He gave me directions, and I walked to the waiting room, feeling sad and uncomfortable. This particular diabetes clinic is known throughout the world for their commitment to care and empowerment of patients. However, I felt belittled and judged in my first encounter there. So, to summarize, at this patient's first adult diabetes clinic visit, the speaker was met with a dismissive, judgmental comment from a front desk staff member, leaving her feel belittled and uncomfortable before even seeing her care team. This story is unique because the negative comment came from a security guard. It highlights that everyone in a clinical setting, no matter their role, plays a significant part of the patient experience, and what they truly say matters. Additionally, because this was the patient's first visit at the adult clinic, the encounter set the tone for all future appointments. Okay, next we have someone living with type 1 for 28 years. In a 20-minute OB/GYN appointment to discuss a GYN issue, the NPI spent the first half of the visit talking about my A1C. She said, "Your level is 6.2 now. It was 5.8 in your last visit. It's not moving in the right direction." I looked at her blankly and said, "You know that the standard of care goal is 7% and it's adjusted to 6.5 only for people when it is safe, and I am below both, right?" She reiterated that it was moving in the wrong direction and that this can be dangerous over time. I felt the need to mention my time in range, but also felt panicked, knowing that there would not be enough time to talk about the GYN topic that I was visiting for in the first place. As a person who has been hospitalized 20 times for severe hypoglycemia, keeping A1C below 7% has never been a recommendation of my endocrinologist. Instead, he supports me in trying to keep my time in range below 70, or keep my time in range below 70, below 4%. I felt angry and resentful that she was not giving me space for the important topic for the visit and was instead focusing on something that she had no history with and no expertise with. I think this story highlights some important themes of there not being enough time in healthcare for conversations regarding topics that are important to the patient. And obviously in this story, this patient came in to discuss the GYN topic, and there was no time left to discuss that because the provider was focusing on her A1C that she did not have expertise with. Also, I think it's important to address that not everyone is in a position or has the knowledge to challenge or correct misinformed comments from outside providers. And this particular person did, very knowledgeable with type 1 diabetes, but if other people receive these comments, they might not know what to do. They might take these as the truth, and they might start to spiral about their diabetes care. Okay, lastly, this person living with type 1 for 12 years. My provider at the time would pull up my pump and CGM reports and ask what I was doing at a specific time before a spike or before going low, etc. When I answered honestly, she would often clarify what I was saying with a furrowed brow, as if in disbelief. And to be fair, I was 22, so I was doing questionable things and was probably too honest about that with her, but I felt really judged. At one point, she had me schedule an appointment with their social worker, which meant I had to pay a copay and take a half day off work at a time in my life when I was living paycheck to paycheck. After a brief conversation with the social worker, she was like, "Yep, sounds like you're 22. I'm not worried." At my appointment with the provider, I told her about the social worker. She seemed irritated. I was never honest with her again and answered all of her questions with as few words as possible. Later, I participated in a clinical trial at a different institution for a SGLT2 inhibitor, and during the trial, my A1C level was 5.4 at my regular endocrinology visit. After the trial was over, during my next visit with the provider, I had an A1C somewhere in the low sixes, which was still lower than my usual A1C. She furrowed her brow and said, "Are you sure you're not taking the SGLT2 still?" And I said, "No, the trial is over." And she said, "But you could still be getting it." I was so shocked that she was insinuating that getting an SGLT2 inhibitor under the table and lying about it. After that, I never went back or told them I was switching hospitals. I just stopped responding to them. So in this story, the speaker describes feeling repeatedly judged and disbelieved by their provider, whose skepticism and inappropriate referrals eroded trust to the point that the patient stopped being honest and eventually left the practice without notice. This story demonstrates a complete loss of trust. There is nothing left. I want you to think about privilege and socioeconomic status. This patient might have had the means or did have the means to transfer to a different provider, but what if she didn't? She might have been lost to care for years and never got the follow-up that she needed. Also, I want to note that the provider might not know exactly why the patient left the practice. The provider could think, "Oh, we just lost her to follow up," when in reality, it was the provider's comments that deterred the patient from ever coming to the practice again. Okay, so these are my results. The frequency of identified themes across patient participant responses. So I have my themes listed on the left, and then my theme descriptions, and then the total number of times that they showed up across stories that were shared. So you can see that the most common themes were moral judgment and negative framing and misinformed care, and then emotional guarding, inadequate support are at the bottom, but still very common. And the total N was 53. Okay, so key takeaways. Every interaction matters. Even brief or subtle comments can leave lasting emotional impact. Clinicians and clinic staff hold immense power to shape how people feel about themselves and their care. And these encounters are more common and more harmful than many realize. Awareness is the first step toward change. I'm sure maybe some of you were shocked by these stories, but they do happen more than you would think, and we need to be aware that this is happening. People with type 1 face so many frustrations beyond the clinic, including insurance, cost, stigma. So compassionate and empathetic care can really make a difference and help lighten that burden. So how can you make a difference? Regardless of specialty or role, basic human decency and respect builds trust. Your empathy and respect ripple outward, influencing staff, trainees, and other providers. So that goes back to the story with the security guard. These people can be highly influenced by how you are treating your patients, so it's important that you're doing that well and serving as a role model. Lead with active listening, empathy, and respect. Celebrate progress, validate emotions, and model compassion across your team. Aim for every person to leave your clinic feeling heard, safe, and respected. And be mindful of bias and stigma when interviewing candidates to really help create a positive and welcoming work environment and positive environment for your patients. Okay, that's all. Thank you.
Claire, thank you so much. That was amazing. My name is Marissa. I'm with Children with Diabetes and Cincinnati Children's. And I think where I continue to struggle is as a person with diabetes as my primary hat, right, if you will, and as a nurse and a diabetes educator as my other hat, secondary though. How do we address this in every aspect of our lives? Because even at this conference, we are all here, we are all engaged, and still some of the language that has been used in presentations this morning has been suboptimal. And I'm just wondering if you've found, like what are the ways that you've found most successful in calling people in and having conversations about the way that they're talking to people without making them feel bad? Because I don't want to make people feel bad. I want to help them move forward.
Thank you for your question. I think that's a really important one. I've experienced kind of like harmful language even among my close friends and family, like people who really care about me. And I know it's not intentional, they're not trying to hurt me, but I think like media and all these stereotypes have it ingrained that we are not using like person first language. It can be very problematic. So I think, as you were saying, like calling people in rather than calling people out, really having just respectful conversations with people, saying, "I know you did not mean to hurt me, but it ended up really, hurting me, and this is what you can say instead," and giving people alternatives. And I know it can take a while to create that pattern of using more appropriate language and person first language, but as long as you keep reminding people and you're not, I know it's sometimes scary to speak up like that, but just kind of surrounding yourself with those supportive people and not being afraid to call them in and educate them rather than make them feel bad about what they said.
Presentation, Claire.
Thank you.
I just wanted to chime in that I'm Alyssa Cabrera at the T1D Exchange as well, and part of the people with diabetes advisory group, kind of involved with that group. And that group is actually putting together some really nice resources with talking points for how to talk to providers, which I know it's awkward, like you're talking up to someone that, has a medical degree, and how you can talk to them gently about some of the language they use, because it can be really awkward. So we've been thinking about like how to best do that, and Claire's been a part of that, and it's been a great project. So coming soon. Oh,
we all have slightly different takes, but we do, I'll make one more plug. So Alyssa and Claire are also supporting the publications committee, and we do have a language guide. It's very brief. It's just 2 pages. Some of you have reviewed, contributed to it, so thank you. I will say, I have a job of sometimes editing some content. So like I've reviewed all of the abstracts for Journal of Diabetes. I will tell you, I go through that and I do a control F for the word control. That's like the first thing that I do. And I spend time and I use better language. So, Marissa, it's not like that's not the best solution, because I'm not even asking you, like you as the first author, like I didn't even bother to like knock on your door to say, hey, the reason why we don't use the word control is there are over 50 factors that impact blood glucose every day. And we can talk about what those things are, and like hormone changes and being sick and not getting any sleep, or, 45 other things. So we don't use that word because it's really triggering. And also like, we just don't have the control in our lives. That's just one word. There are a bunch of others, and I kind of cringe when I hear them. I do think it's a pattern. Like I was using the word control 8 years ago, and then I met Jane Dickinson and I read her paper, and she helped me to understand how it impacts us. And, I remember we have like small groups who talk about these things, and somebody with diabetes said, well, I don't care, like as a person with diabetes, I don't care if you call me diabetic. It doesn't matter to me. But actually, if you keep using that language, even though you think it doesn't impact you, it really does. So keeping our humanness first is really important. So us being intentional in our language use, we can help each other. It is a process. It doesn't like that. It's taken me, I think, at least 5 years to remove control from my vocabulary for diabetes descriptions. So we'll help you. I don't want to do control F forever. I'd like to bring you along with us in this thinking about language guidance. So don't feel like you're being judged for if we're kind of marking up papers, but we do want to use our intention is person first language in this. So thank you. And thank you, Claire, for presenting. That's it. That's a great point. Yeah. Yeah.
Hi, Thank you for your talk. I'm Tina Davis. I'm here in Atlanta at Kaiser Permanente, Georgia. I work in the research in the Center for Research and Evaluation. So thank you for bringing the voice into the room. So I really, really appreciate hearing people's experiences. I'm curious too, when you talked about people shifting to a new practice, right? And not telling, I'm wondering if anybody talked about doing multiple shifts, right? Or if they just kind of say, well, I tried one, I'll suck it up, right? Like, I'm curious about multiple hops to different providers, if people talked about that.
Yeah, no one that I interviewed for this talked about multiple hops to different providers. But I imagine if people have the means to do that, that would be a very feasible scenario. Uh, yeah, so yeah, no multiple hops, but again, it is a matter of cost and location. There's so many factors that go into that.
And
So
I'll just pipe on. We'll pipe in on this too. So we talked about regionality, like obviously if you're living in a state where there is not another endocrinologist in 100 miles, it's a very different experience. But if you live in a dense city, it is not helpful to transition 6 times in 2 years. Like that's not a good experience. It's not good care. So we want to prevent those and not have people transitioning. And I would love it if people with diabetes would speak up and not just kind of quietly close the door on their practices, but to give feedback. Like it doesn't help you as practitioners to not know that somebody had a bad experience.
Right? Like, do you have that? So, I don't know. I hate the patient stuff.
That's a great point. Thank you.
That's a great point from Tina. I wanted to piggyback off of that because I think I'm also someone who lives with type 1, but find myself in a lot of deep and sometimes awkward conversations in a clinic visit, and probably don't have the right words at least 50% of the time. But I think I want to ask about how to be careful with things like Nicole is bringing up about using the word control, because I do think there is a time and place and a way to use those words where we shouldn't be fearful of asking someone to comment on that. I think they're part of the language that people are going to encounter, but having maybe the right type of discussion using that or involving, the person that's sitting in front of you to use that in a positive way. Can we reframe that? I think there's a lot of avoidance of language, but maybe it's also helping people use it in a better way. I don't know, because I think if we start also just not talking about some of the things we do have control or want control over, I know it's a different context, but I also don't want providers to be told, these are a list of things that we can't say. Well, correct. In the right context, they should be avoided. But I think it's about engaging the right conversation. And I think it's going to take a lot more effort and education, at least. Maybe it's not working, but I also need help in a more comprehensive way than. So hoping that we're going to be working on that still.
So I want to just comment. I know Alyssa said it earlier, but I'm a co-chair of the PWD committee. And I think that's our main focus right now is not only giving patient the words, but also providing education for other providers around. I've had type 1, now my daughter has type 1, and I do have to say, I gave my daughter, I said, no one knows what diabetes is. Like I gave her that knowledge early on that other parents don't know to give their kid and themselves, and they're shocked. So I think like some of the handouts and things we need to prepare for people are what to expect, what's out there, what words you can use if you do feel like you want to educate, because some people might not want to, and they might just want to know this is normal. People don't understand, and I don't feel like educating today. And then also education materials for providers, not only in diabetes world, but all around. So we would love input, whether it's wording or whatever it may be. Feel free to contact Emily or myself, and we would love feedback on everything we're making right now, because I do think that is a big focus. And I see other groups beyond type 1 is doing a lot of stuff. Like there's a lot that's we're trying to change this type of experience that people are having. So that's all.
And
there it is. Thank you. This is actually not a Zoom question. It's a Don comment. But what I want to suggest is this, is we're also doing quality improvement. And this conversation is really good for those of us that are practicing that science. And oftentimes there's a big difference between us trying to control a process and manage a process. And we use the word process control charts. Do you remember that phrase? That grows out of industry, where you're comparing the use of physical items and you have greater opportunities to control. Really, we're doing process management. And so it's not as if you can't say control. This is not policing language as much as it's thinking what real accurately describes what it is we're engaged in together. And so oftentimes in quality work, I use the word management rather than control. I'm not sure how transferable that is to clinical work, but I'll offer it up anyway. Thank you.
Okay. Does this working?
Yes.
Oh, okay. Hi. I'm Laurel Kester. I'm from the Helmsley Charitable Trust. And this has been an amazing discussion. I really feel very lucky to have been able to soak everything in. I have so many thoughts and ideas, but in relation to this conversation that we're having right now on language, I mean, we've talked a lot. I guess I'm wondering, from the community's point of view, we've talked about, onus being put on the person with diabetes, on providers, but I've also heard, what about the high-level drivers? Like ICD-10 codes were mentioned. So how do you change the language of ICD-10 codes or diabetes journals? I think I would welcome conversation on, I think there's a role at kind of every level, but also in my work at Helmsley, not only around T1D exchange, but I think a lot about like what to do at the health system level to kind of top down. And there are, of course, like approaches from bottom up. But if there is a, mechanism to change the language that is being used by everyone, like ICD-10 codes, another area that we're working in is measures with NCQA. They have changed at least one of their diabetes-related measures, I think, thanks to some of our being able to work with them, to glycemic management. So I guess it's not a question. Well, it's a question and comment, and appreciate the discussion.
Yeah, I definitely agree with what you're saying. I think like a top-down approach is definitely needed, rather than a bottom-up approach. We can't put all of the responsibility on the patient. I think what I have to say is like a lot of this language can start from kind of education when we're younger. I know, at least in my school, there was no type 1 education and there was barely any type 2. So when I was diagnosed, I had no idea what was happening to me. But I think even that, just educating young kids to grow up or to adopt more inclusive and appropriate language surrounding type 1 and other conditions can really help. I don't know if I can speak to like the ICD-10 codes, but Nicole will take over.
Yeah. So Laurel, thank you for your comments. I would say changing the systems would be excellent. And I've noticed, if you submitted a paper to like the ADA 6-7 years ago, you got away with using the word control. But if for those of you who have gotten papers back over the last 2 or 3 years, they will call you out now. So reviewers will say use person first language. And I was so excited to see that, because I was sort of I was trying to change it at the local level, but not realizing that other people on the other side would be doing it. So I think the ADA is there now, which is excellent. I don't know, Dr. Golden, I appreciate your point of the ICD-10. I don't know how to penetrate ICD-10, but I would love for us to at least, advocate and talk to them. So I think we can set up a meeting and make that request. I think it's totally reasonable. And if NCQA is moving in that direction, we have a precedent. So thank you. I think do we have one more? Yeah.
I'll be brief. This is Mary Scott with Endocrine Peds Endo at UAB. And I've lived with type 1 for 36 odd years, but and having taken care of both kids, I like to remind the audience, who I think you guys all know, but it's easy for people with type 1 to deflect those kind of comments by saying, no, that's type 2 diabetes. But in reality, especially the pediatric endos out here, we know that type 2 diabetes is not entirely caused by what you eat and your lifestyle, that so much more of it is genetic and epigenetic and environmental, that we need to encourage people to be mindful of that. Two, I've brought this up at a couple conferences, but I love Abbott's commercial about it's like microaggressions. If you just Google the Abbott commercial about even microaggressions that might pop up, but it's a minute and a half. It's great to show other providers, trainees. It's a guy who's basically walking around, and every time somebody says something about his diabetes, a new post-it attaches to him. And it's about all the crap you hear from people all day long about, are you supposed to be eating that? What are you doing? And I think that's helpful. And then third, I have advocated for this for the longest time ever, but can we please stop allowing patients and as providers using the word brittle, because it makes me really angry. It's not a different kind of diabetes. It is diabetes with a lot of swings. And people need to understand, because a lot of patients take it as a sicker label and they like it, which I dislike about that label. Or providers have told them they're brittle, which then is giving it a judgment. And so, but that's my least favorite word of all. And if someone would never say it again, that would make me very happy. So. And also everybody on the ICD-10 committee, from what I heard, most of them were surgeons and there were no endocrinologists on that committee.
I just want to thank everyone. Thank you.